Welcome to today's webinar, Multiple Myeloma in African Americans, Understanding Differences and Incidence and Treatment, brought to you by the Multiple Myeloma Research Foundation and sponsored by AbbVie, Amgen, Bristol Myers Squibb, Celgene, Genentech, Janssen, Karyopharm, Novartis, and Takeda Oncology. It is my pleasure at this time to turn it over to Mary DeRoma at the Multiple Myeloma Research Foundation, who will begin the webinar.
Hi, everyone. I'm Mary DeRome, Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. Thanks so much for joining us for today's webinar. I'd also like to thank AbbVie, Amgen, Bristol Myers Squibb, Celgene, Genentech, Janssen, Karyopharm, Novartis, and Takeda Oncology for providing educational grants to support this webinar. First, I'll tell you a little bit about the MMRF. The MMRF is a patient-founded organization started in 1998 by Kathy Juicy, soon after she was diagnosed with multiple myeloma. We have a keen sense of urgency and a laser focus on extending patient lives. As many of you know, multiple myeloma is a highly heterogeneous disease, which means every patient's myeloma is different. So our goal and our mission is that each patient should receive treatment specific to his or her type of myeloma. That is the promise of precision medicine. With such a high degree of diversity in this disease, we are focusing on generating and gathering as much data as possible to capture the full picture of myeloma. The cornerstone of this effort is our COMPASS study, which now has the largest genomics data set of any cancer. We make sure that all of the data that we collect is available to researchers worldwide to develop hypotheses for new, more precise treatments. And then we can push these hypotheses into clinical trials. This is our end-to-end precision medicine model. We are already expanding our genomic data collection efforts beyond COMPASS into relapsed refractory patients and smoldering MGUS patients. Last year, we announced several multi-million-dollar investments that leverage this model, one in immunotherapy, one in prevention, and one in answering the most important questions from the myeloma community. You can read about these initiatives and our model on our website. To follow all of the latest research and educational updates from the MMRF, I strongly encourage you not only to visit our website, but also to follow us on Facebook and Twitter if you're active on those channels. Now I'd like to introduce our speakers for today's webinar. So Dr. Alawati specializes in the treatment of plasma cell disorders, particularly multiple myeloma and Waldenstrom's macroglobulinemia. His research focuses on evaluating therapeutic strategies and developing new treatments for these diseases. He also carries a special interest in health services and outcomes research with a special focus on healthcare disparities among racial and ethnic minorities in the United States. Dr. Alawati currently serves as an associate professor with the Division of Hematology Oncology at Mayo Clinic in Jacksonville, Florida. Dr. Wendy Cozen's areas of expertise include causes of lymphoma, including Hodgkin's lymphoma, multiple myeloma, and non-Hodgkin's lymphoma, aging in cancer survivors, and the effect of immune cells in tumors on survival. Dr. Cozen is currently conducting several studies on biological aspects of health disparities, including causes of multiple myeloma in African Americans. Dr. Cozen currently serves as Professor of Preventive Medicine and Pathology, Leader of Translational Epidemiology, and Director of Population-Based Tissue Procurement Core at the University of Southern California Keck School of Medicine, Master of Public Health program. Amy Pierre is a member of Sigma Theta Tau, an international nursing honor society, and she was awarded a scholarship by the American Cancer Society for academic achievement and contribution to oncology care. She is actively involved in the development of multiple myeloma nursing education programs and is a member of the International Myeloma Foundation's Nurse Leadership Board. Ms. Pierre currently serves as the hematologic nurse practitioner at Memorial Sloan Kettering Cancer Center in Montvale, New Jersey. Today, Amy, Wendy, and Sikander will provide information on the following topics. They'll be talking about signs and symptoms of myeloma, the importance of education, awareness, and communication with your healthcare team, the incidence and risk of precursors to myeloma in African Americans, and clinical aspects of active myeloma in African Americans. Now it is my pleasure to turn the webinar over to Amy Kier. Amy?
Thank you so much, Mary. So first, we're going to start off this presentation today by doing a brief disease overview of multiple myeloma. So myeloma is a hematologic malignancy, or a blood cancer that develops in the plasma cells in your bone marrow. The bone marrow is that soft, spongy tissue at the center of your bones. Now, the job of a plasma cell, which is a particular type of white blood cell, is to make antibodies, or immunoglobulins, to fight bacteria and viruses to stop infection. But in myeloma, we see that normal plasma cells have transformed into malignant or cancerous cells and produce large quantities of an abnormal immunoglobulin or antibody, also known as a monoclonal protein or an M protein, that's not functional, not helpful for your immune system. These malignant plasma cells can accumulate and overcrowd the bone marrow and not allow the bone marrow to do its natural function. And these excess monoclonal antibodies can also negatively impact certain organ systems, such as the kidneys or the bones, and disrupt normal bone marrow function. The symptoms of presentation or diagnosis of myeloma is directly due to the effect of the monoclonal proteins on the body. So we can see low blood counts due to these malignant plasma cells overcrowding the bone marrow. The job of the bone marrow is to produce all your blood cells, so your white blood cells, your red blood cells, your platelets. So if it's overcrowded, we can see low counts, particularly anemia, which is the most common symptom at presentation of myeloma. We can see it in about 73% of patients. And when patients are anemic or have low hemoglobin levels, they can feel weak or tired or even short of breath. And we can see low white blood cell counts at times due to the bone marrow being overcrowded with the plasma cells, and that can increase patients' risk of developing infections. We can also see decreased kidney function due to direct effects by that monoclonal protein, specifically the light chain proteins, and we can see this in about 19% of the time at diagnosis. The kidney damage can be so significant at times that patients may require dialysis, but that can be reversible with treatment of the myeloma. We can see kidney dysfunction in about 50% of patients over the trajectory of their illness. And we can also see bone damage. The myeloma protein can upregulate the activity of a cell called an osteoclast. And an osteoclast breaks down bone. It works in tandem with osteoblasts that build bone. So if you upregulate the activity of an osteoclast, we can see thinner, weaker bones, also known as osteoporosis. You can see holes or soft spots in the bones, also known as lytic lesions. And we know that weakened bones are easier to fracture, which can cause pain. And they can fracture even under the smallest amount of pressure. This widespread bone damage or destruction can lead to high calcium levels in the blood, also known as hypercalcemia. And this can happen in about 13% of the time at diagnosis. Hypercalcemia itself can also be tough on the kidneys, and it can make a patient feel weak. It can also lower their appetite, make them feel nauseated, even at times confused, and can also cause constipation. But we do know about 10 to 20% of patients at diagnosis actually may not show any sort of symptoms at all. To diagnose multiple myeloma, we conduct comprehensive tests, including laboratory studies, a bone marrow biopsy, an aspirin, and even imaging tests. Now, a CBC is a complete blood count. It quantifies the cells that are in the blood. So this is the white blood cells, the red blood cells, and platelets. And these are all the cells that are made in the bone marrow. We also do comprehensive chemistry studies. We're looking at your albumin level, which is the most abundant protein in the body that's produced by the liver. It can be lowered in myeloma, and it's helpful for staging purposes. We also look at the calcium level to see if it's elevated. It's important to determine if someone has symptomatic or asymptomatic myeloma. We look at a test called the LDH, the lactate dehydrogenase. It's useful for staging and prognostic indicating. And we look at the kidney function too through the BUN and creatinine. We also draw a test called a beta-2 microglobulin. So this indicates the amount and activity of the underlying myeloma, and it's useful for staging. And we'll do a serum protein electrophoresis, or SPEP, and a urine protein electrophoresis, or UPEP, which detects the presence and the amount of that monoclonal protein. We'll also do a serum or urine immunofixation, or IFE, which tells us the exact type of that monoclonal protein, and we'll also do a free light chain assay. The antibodies are made up of two different molecules, a heavy chain portion and a light chain portion. Sometimes it's not entirely intact in myeloma, and we can see excess light chains floating around in the bloodstream. Myeloma grows within the bone marrow, so conducting a bone marrow biopsy is really the only way to analyze the myeloma cells to see what their cellular genetics are and how they compare to normal plasma cells. And from here, we can also see exactly what antibody they express, or their clonality. We typically use the posterior iliac crest for the bone marrow biopsy, so if you put your hands on your hip where your thumb lies, that's typically where they're doing the biopsy. That's where the bone marrow is really rich. And from the bone marrow biopsy, we can do cytogenetic testing, or karyotyping, which is basically looking at the chromosomes of the dividing or growing myeloma cells to see if there are any chromosomal abnormalities. We'll also do FISH studies, also known as fluorescence in situ hybridization, which is complementary to cytogenetics, and it looks for chromosomal abnormalities whether the cells are dividing or not. It's a complete assessment of the numerical and structural abnormalities of the chromosomes. We do imaging tests to look at the bone structure and determine if there's any tumors in the bones, the size and the number in the bones. And the X-ray is usually the first bone imaging modality that patients undergo at diagnosis. And we're looking to see if there's any bone damage related to the myeloma, whether it be those lytic lesions or fractures. Now, an MRI is a more detailed imaging test than an X-ray. It uses magnetic energy to produce a detailed image of the tissue and the bone, and it's helpful to see early focal lesions. It can also show these tumor collections of the myeloma known as plasmacytomas, and it's really helpful to see the integrity of the spinal cord. Patients who do have metal implants can't go under MRI imaging modality. We also do CAT scans or CT scans. They're more precise than an X-ray. They also show soft tissue masses and detailed fracture risks. They're not as sensitive as an MRI in showing lesions outside the bone marrow, and it does use radiation. Now, a PET scan looks at the body from head to toe. It's very sensitive in detecting tumor activity. Patients are injected with a sugar molecule prior to the scan, and areas that glow can be areas that uptake this molecule and are consistent with areas of fast metabolism and can reveal areas of active cancer. It can detect focal myeloma within or outside the bone marrow, and it's really a helpful imaging modality to monitor patients who may not secrete that myeloma protein, who can't be monitored by blood or urine studies. So myeloma falls under the category of plasma cell dyscrasias, and we know that each myeloma patient at one point was either a smoldering myeloma patient or an MGUS patient. And there are specific criteria that details each subset of these plasma cell dyscrasias. So an MGUS patient, monoclonal gammopathy of undetermined significance, those patients produce that monoclonal protein at a low level. We find it at a low level in their bone marrow, but they don't really have any end organ damage. That monoclonal protein is not bothering their system. And they do have a risk of transforming to active myeloma, roughly 1% per year, so those patients need to be monitored over time. Now, smoldering myeloma, we do see a higher percentage of that abnormal plasma cell in their bone marrow and a higher level of that monoclonal protein in their blood. But again, it's not causing any sort of end organ damage or myeloma-defining events. But these patients do have a higher risk of transformation, roughly 10% per year for the first 5 years, and then it tapers off over time. Now, active multiple myeloma, we see that these patients have that monoclonal protein, and we do see evidence of a myeloma-defining event. Now, we use CRAB criteria to help define this, each letter standing for a different issue. So C stands for the high calcium levels in the blood, R stands for renal dysfunction or kidney problems, A stands for anemia related to the myeloma, and B stands for bony lesions. If a myeloma patient meets CRAB criteria, they have active symptomatic myeloma that requires treatment. But there's also some other criteria that we use too. We use a high percentage of the clonal plasma cells, greater than 60%, or abnormal free light chain assay, or even a focal lesion on MRI, and qualify as active myeloma. Once we've established a diagnosis, we can then appropriately stage a patient. And staging can be important in myeloma because it gives us prognostic information and gives us an idea of the level of burden of disease at the time of diagnosis. And we determine this by our comprehensive blood tests, imaging, and our bone marrow results. So stage 1 patients, we don't see that high level of tumor burden. We do those genetic testing on their bone marrow biopsy, and we don't really see any high-risk features. Stage 3 is the opposite. So we see a larger burden of disease. We can see maybe high-risk features in their gene analysis, maybe what we call presence of deletion 17p or translocation 414 or 1416. And then stage 2 is basically you don't really fall nicely into either category 1 or category 3 in staging. And staging can help us tell us how aggressive your myeloma is and can help drive decision-making for treatment and for care. So as a patient, it's important to advocate for yourself and participate in shared decision-making for optimal outcomes. So be vocal and ask questions, write them down, bring them to your care team so you can make informed decisions about your care. Myeloma is a relatively rare malignancy. It only makes up 1.8% of all cancer diagnoses, so it's important to know the level of experience your care team has in treating myeloma. You know, what is the volume of myeloma patients that they see? How many do they see monthly or annually? And what type of myeloma do you have? Because everyone is different. What stage is your myeloma? Is it already affecting your kidneys or your bones? What are the genetic abnormalities in your bone marrow tests that categorize you as a standard risk or a high-risk patient? It's important to know this for prognosis and understanding how aggressive your myeloma is. What are your treatment choices? What is recommended specifically for you and why? What are the risks and benefits of each treatment choice? How do you control the side effects of treatment? How can you properly prepare for treatment? And what are the resources that are available to you? There are many nonprofit societies or agencies that have grants for patients for copay assistance or even transportation assistance or even emotional support. And a clinical trial, is it appropriate for you, or can you help me find an appropriate clinical trial? There's many clinical trials that use standard of care treatments for myeloma patients and augment it with a drug that we know to be effective in myeloma, but is still being studied. So clinical trials can give you early access to drugs that can be effective. And there's also some clinical trials available for smoldering or asymptomatic myeloma patients who have high-risk disease, who would not be treated otherwise. So it gives those patients early access to intervention. There are key considerations for optimal disease management: comprehensive lab tests, imaging, chromosomal testing, and it's important to investigate the options for tissue banking for the purposes of research so that the data can be used to drive research and can help you and future patients match appropriate drugs to their specific genetic or molecular profile to make treatment more tailored and individualized. Know your stage and your prognosis. Obtain a second opinion if you aren't able to see a routine myeloma specialist. You can see a specialist at an academic center who can help participate in your care. Understand what the standard of care is for myeloma, and always consider clinical trials as an option. So to summarize, we know that myeloma is a blood cancer from plasma cells that are found in the bone marrow. It is a rare malignancy, but it is the second most common hematologic cancer, second to non-Hodgkin lymphoma, and it does have established risk factors that we're going to outline for you today. The symptoms at diagnosis are usually due to disease complications that happen in the bone marrow or the bones or the kidneys. And understanding your specific disease and communicating effectively with your care team is really key for optimum patient outcomes. Now I will hand over the presentation to Dr. Wendy Cozen.
Hi, good morning, everybody. At least good morning from the West Coast. And I am going to talk to you today about risk factors and the occurrence of multiple myeloma. And my field is epidemiology, which is the study of causes of disease in people. And the reason that's important, it's not the same as looking for new treatments, because if we find the causes, we might be able to prevent the disease in the first place, as we have with smoking and lung cancer, and now with the Gardasil vaccination and cervical cancer, and then then the person that will never develop the disease. So we're on the active hunt. So first, as Amy in her excellent review gave, that here we have what's supposed to be a plasma cell, and that develops into MGUS, which is a precursor condition which every myeloma patient passes through. kind of like getting an abnormal pap smear that then in some people goes on to cervical cancer. So this is an excellent place. That's why I have an arrow here. If we find out the causes, we can stop the progression. A certain proportion of people go into the smoldering stage where, as Amy said, and then eventually to myeloma and sometimes to myeloma outside the bone marrow and even into a leukemia phase. Now, what happens along the way is that mutations, these are all different kinds of mutations. Some of them are the chromosomal abnormalities that the cell picks up on its way to progression, but we don't have a really good handle on why. So the first thing I'm going to be showing you are some slides about the occurrence of multiple myeloma, and I want to give you one epidemiology 101. So what we typically do is we count new cases, because you can't count cases that are already in existence. So it's brand new cases that are diagnosed, and we do this through cancer registry. So in the United States now, every state is covered by a cancer registry, and new cases of cancer are reported and then eventually reported to the National Cancer Institute and to the Centers for Disease Control, just like certain infectious diseases. And then we don't compare just numbers of cases, because you can't compare Montana to New York, for example, because there's different numbers of people. So we make a rate, a per capita, and you compare the new number of cases diagnosed every year, the average number, per 100,000 people at risk. Where does the 100,000 people at risk come from? The census. And that's why it's really important to answer all the census questions. So that's how all these are done. Now, here we have all these cancer registries that participate around the world with the World Health Organization, and this has incidence. On the left, it's in men. On the right, it's in women, and these numbers represent the average number of new cases per 100,000 people at risk per year. So you can see it's pretty rare. We're talking about 6 cases per 100,000. But, of course, the thing that you notice right away is that African Americans have the highest risk in the world. We don't have a lot of cancer registries in Africa right now. They're just starting to come along. But the next closest thing is Martinique in the Caribbean, which also has a lot of people of African ancestry, and that, too, has higher risk both in men on this side and women on this side. And the other thing of note is that in Asia, it's particularly low. So that's another thing that we don't understand. Now, to go to the United States, these are the number of new multiple myeloma cases per 100,000 people per year, and this was 2011 to 2015, and this is the cancer registry data compiled by the National Cancer Institute. The thing I wanted to show you is this is by age. So these are 5-year age groups, and then these are the number of new cases per year, and immediately you see that age is a big risk factor. This disease goes up with age, and that males in red have higher risks than women, especially at older ages. So this is a male-dominated disease. And then if you look by racial ethnic group, you see the red in the males. The red is African Americans, and that far outpaces other racial ethnic groups. And it tends to start a little bit early as well. Now, one thing to notice is these are different scales. This is up to 150 cases per 100,000, but in women it's only 80. So women are about 2/3. It looks the same. It's the same shape curve, but the actual numbers are higher in males. And then Hispanics and non-Hispanic whites have roughly the same age, but they don't shoot up in older ages the way African Americans do. And then you have Asians, and once again, a much lower curve, a much lower rate with age for, again, reasons we don't understand. So that's the occurrence picture, and I'm going to skip this slide and summarize. So we have the demographic risk factors are older age, male sex, very high in African Americans. Interestingly, Jews from Europe who came here from Europe have a higher risk. In Europe, it's Ireland and Italy, and then we, as I said, we have the lower Asian rates. So if you put everybody together in the United States with all ages, it's about 6 to 7 new cases per year per 100,000 people. But in African Americans, it's 13 per 100,000, so much higher, over 2 times higher. Now, MGUS. MGUS, as we said, is a place you can intervene. If we catch people with MGUS, then maybe we can do something about it. So what are the statistics for MGUS look like? The problem with MGUS is that it is not captured like myeloma is by cancer registries, because it is often diagnosed, and maybe Dr. Alawati will say something about that later. It's diagnosed sometimes by accident. Most people don't know they have it, so it's diagnosed on a test when you have too much protein in your blood. And here is what we know mostly from hospitals and kind of coincidental studies. So this is MGUS, not myeloma. This is the precursor. So at 50 years, about 1.5 to 3% of the entire population have MGUS and probably don't know it. By the time you get to 70 years, it's about 3 to 5%. So this is just in the population. Males have, a little more than twice as much as females. The interesting point and the important point is that people with African ancestry have 2 to 3-fold prevalence of MGUS. So it doesn't start with myeloma. This race disparity starts with MGUS. The interesting thing is that unlike the other groups, it doesn't increase with age in the 70s. So it starts high and it stays at that level. There's been studies done in Japan, quite a few, and Japanese individuals have a lower prevalence of MGUS, and so probably they have a lower prevalence, that's why, of myeloma. The progression right now in the literature, the progression from MGUS to myeloma, as Amy said, is 1% per year, and what's published right now looks like it's the same in different ethnic groups and racial groups, so there's no difference. Now, I saw one presentation at one of our meetings 2 years ago that suggested that the progression might be higher in African Americans, but it's never been published, so it has to be reviewed. So what we're left with is this statistic, which really says there's no difference across different groups. So the reason that African Americans have higher rates of myeloma is because they have higher rates of MGUS, which, we're trying to intervene. Now, you can't follow all MGUS patients because if 5% of 70-year-olds in the United States have it, that would be cost prohibitive. And right now, people don't really know what to do with it. So, it's just, we don't know how to determine somebody who's high risk and somebody who isn't. Mayo Clinic, where Dr. Alawati is, has identified a nice laboratory panel which can kind of predict who's at higher risk, but we don't know risk factors that could be improved. Now we're going into studies that look at actual risk factors, the causes that I was talking about. And to do this, we typically find multiple myeloma patients, and then we have to find a set of controls who don't have myeloma patients who come from exactly the same source population. That's very tricky. It can be neighborhoods, we can find it by phone, whatever, and then we compare different characteristics by blood or by questionnaire. So the big thing that we found, the number one thing, is body weight. People that are overweight have an increased risk of about 10% for myeloma compared to people who aren't. People who are obese have about a 40% increased risk. People who are obese as a young adult have a really high risk. So we think what that means is if you have been obese all your life, then you have a very high risk. And here it's by 2.2-fold or by 220%. So these studies were done. There were several studies that included African Americans, and it's the same general effect. It doesn't look like the effects are particularly higher, so this is an independent effect, independent of race and ethnicity. Interestingly, this is the same for non-Hodgkin's lymphoma. Alcohol actually looks like it decreases risk. Now, don't go out and drink a bunch because that's bad for other things, but this is an unexplained finding that we have. Smoking has no effect on this particular disease. Fish and seafood, there's been very few diet studies, but it looks like a tiny bit of decrease in risk. But the thing that we really know about is obesity. Now, there's been some studies that have done studies of obesity and MGUS, and even more interesting, of MGUS progression. And BMI stands for body mass index, which takes height into consideration as well. So it looks like a higher body mass index at a younger age is associated with an increase of both MGUS and myeloma mortality, which is more pronounced in women. There was a very important study done in a great cohort called the Southern Community Cohort that recruits people throughout the South, African Americans and whites, and they looked in women, and both African American race, ethnicity, and obesity were risk factors for MGUS. And this seemed to be independent of race, and it seemed to be, and the next point, independent of socioeconomic status. One interesting point about socioeconomic status, which is education income. In some of these case control studies, it looks like that people of lower social class might be at risk. But in Los Angeles, where we have a map of it doesn't matter who participated, it's a map of every case in Los Angeles since 1972. It actually looks like for African Americans, it's higher social class. It's highest in the area where in Los Angeles our high social class African Americans live. There's a particular area, that's where it's high. So that's really interesting. We don't know why. Going back to obesity, mice who have been fed high-fat diets, they kind of develop myeloma. So it does look like there's something about getting fat that induces myeloma. And then there's been a series of studies in U.S. veterans at VA hospitals, obviously just men, that show some evidence that among veterans with diabetes, those that took metformin actually decreased the progression of MGUS to multiple myeloma, and also that myeloma survival was increased among diabetic patients. And there's been some studies where they actually put metformin on a cell culture of myeloma cells that seems to inhibit the cells. That is not definite. People are talking about trials and see what we can do because it would be pretty easy, but more studies need to be done. And this is a slide from one of those studies. And if you look at this part here, these are the months of survival, okay? And you see two lines. You see a blue line where people seem to get myeloma, I'm sorry, it's not survival. It's the time from being diagnosed with MGUS to being diagnosed with myeloma. And you see that these people are diagnosed faster, and the people on metformin were diagnosed slower. So that's an example of finding a risk factor and then trying to figure out how it can be used for prevention. So stay tuned on that. Now we move from environmental factors to inherited factors. This is family history. If you have one first-degree relative, which of course means a parent, a child, and a sibling, your risk of myeloma is increased by 90%, 1.9-fold. For men, it's increased by more, 413%. If you are African American and you have a first-degree relative, that is even higher. It's increased by 552%. And that is a signal for those of us in my field to say, hey, there might be something genetic going on here because it's increased in family members. There's been studies, again, at Mayo Clinic that show that if there's a myeloma patient in the family, those family members around the myeloma patient tend to have more MGUS, the precursor. So it seems like there's something familial or genetic going along with that whole plasma cell dyscrasia. There's a very rare disease, it's kind of like Tay-Sachs, where it's an abnormality in an enzyme that processes lipids in cells that is only in Jewish people, and it's called Gaucher's disease. Those people have a huge risk of myeloma and MGUS, 6,000% or 60-fold risk. So it's rare, so it's not going to have a big impact on the population, but it could give us a clue that, again, this has something to, to do with fat. Now, this is because we saw that there were familial risks, we wanted to look and see if we could identify which genetic abnormality. So bear with me for a minute. You saw the chromosomes and the karyotyping that Amy showed. So now we've designed a test where we can take somebody's blood, take out their white cells, extract the DNA, and then do a comprehensive examination to look at up to 8 million of the 10 million genetic variants in each chromosome across the genes to see if cases have different variants than controls. And that's what we've been doing in many, many diseases. And it's called, if you ever see this word, a GWAS, a genome-wide association scan. So just like other cancers, our field has been going like crazy looking at other cancers. The problem is it's almost always in whites, and that does not help the general population very much. So in whites, but mostly English and Germans, there were 23 different variants that were identified that have, if people have this variant at this location on their chromosome, they have an increased risk of myeloma. Usually it's only about 1 to 2, 1.5 to 2-fold, so 50% to 200%. And each of these things right here, these are the numbers of the chromosome, and each of these little dots show a different genetic variation. So if you see a whole bunch of them right here, that means that that locus, that's a hot locus, and variants at that locus are associated with risk. And this is the significance, so that means it's significant. It's not just due to chance. So what we did, actually in collaboration with people on this call, in collaboration with Dr. Halawadi, who's a co-investigator, and in collaboration with the Multiple Myeloma Research Foundation that provided some samples to us, we decided to do the first large study of these genetic risk factors in African Americans. We ended up with 1,800 patients, which was hard to do, very large, but still, by these studies, a small study, and 7,000 unaffected African American controls. And what we found is of all these variants in whites, 9 of them were also definitely associated with risk in African Americans. So that means it's probably a true signal present in different groups. And then 11 of the 23 variants were probably associated. We probably didn't have enough numbers. Then what we did is if you add up all the bad variants, like say somebody has 23 out of the 23 bad variants, it looks like if a person has at least 17 and maybe more bad variants, their risk of developing multiple myeloma was increased by 82% among African Americans. But remember, these are all based on these genetic variants that were found in whites. We did not find any definite genetic variants that explain the risk disparity, which we were very disappointed in, but we're going to keep looking. And we probably need larger numbers of patients, so we're working with the National Cancer Institute to see if we can do that. So that's the genetic story, no magic bullet. I will say for prostate cancer, not true. In prostate cancer, they've done the same kind of studies. Instead of 1,800, it's such a more common disease, they have 150,000 patients. And about 177 of these genetic variants have been identified that actually explain most of the African American risk. So in prostate cancer, they have found these genes and they explain it. Here's some other interesting new risk factors. This just came out this year that the 9/11 first responders that rushed into the building, the firefighters, some of the police, have actually been getting higher levels of MGUS and higher levels of multiple myeloma, a higher occurrence of multiple myeloma. And then looking in the literature now, it looks like firefighters do too. So we don't know what exactly it is. It could be products of combustion, which are risk factors for other types of cancer. It could be, inhaling it, or it could be a specific chemical in the buildings. We don't know, but this is the first time I've seen an environmental risk factor that I actually believe. So that's something a lot of people are going to be following up on. Agent Orange is controversial, whether it really does or it doesn't. I'm not totally convinced. Radiation, these studies mostly come from, believe it or not, the atomic bomb studies in Japan, and it hasn't been really strong. But maybe it hasn't been really strong because, as you saw, Japanese have a lower rate in the first place, so we're not sure. There's some information that maybe solvents in paints, occupations that deal with solvents, and then agriculture has always been associated with both non-Hodgkin's lymphoma and myeloma risk. But we don't know what it is. We don't know if it's exposure to animals with animal infections and all the germs that come with animals, or pesticides. That's still undecided. So these are possible. Stay tuned, more studies. So finally, some of the mechanisms that might cause this, because we have these risk factors, but we don't know why. It's possible that factors that stimulate or support B lymphocytes dividing and becoming plasma cells along those lines and MGUS clonal expansions could be responsible. And it turns out that fat cells themselves produce some molecules, some proteins that support plasma cell growth. So that could be why, obesity causes it. That's one thing. The second thing is that the thing that really interests me is that you see that MGUS increases with age. It does anyway, even if you don't go on to myeloma. Why? So I think as we age, maybe there's some immunological change, our immune systems change, and we can't control this plasma cell division, and we're just starting to look at that. And then a lot of people, this would be the last one would be more of the environmental, like the firefighters and that sort of thing, causing damage to the lymphocytes going through the stages, and then they acquire mutations, and that's what a lot of people are looking at too. So I'm going to leave you with important questions in my field that we're trying to look at. Let's start with the blue one first. Can we identify risk factors that are responsible for the excess risk of MGUS and African Americans, and especially risk factors that can be modified so we could have an intervention? The second thing is, the red one, can we identify the high-risk genetic variants, especially in African Americans, so we can screen MGUS patients and say, hey, you're at higher risk, we're going to follow you more closely, or family members of patients whom you've seen have a much higher risk. And then the first one is, can we identify factors that cause MGUS to progress and then prevent it so that we don't get a progression? And with that summary, a lot more to do here, I gladly turn over the talk to Dr. Sikander Alawati, who will discuss the clinical aspects of the disease, my good friend and colleague.
Thanks a lot, Wendy. And thanks, everybody, for joining in. This is such an important and interesting topic because unless and until we understand where we are with the disease and who it affects, to what extent, I don't think we can get to the most appropriate treatment and benefit to all the patients. Plus, you may also have heard all these information about precision medicine, targeted medicine, etc. I think this particular discussion today is bringing us back to the basics to say, well, do we fully understand what causes myeloma in which patients, and can we actually treat them appropriately with that whole idea of targeted and precision medicine? So I'll take you through some of the more clinical aspects, which will talk about focusing specifically on African Americans and what our understanding is how we tackle this. So I'll touch upon some genetic differences. Remember, what Wendy spoke about was if we understand why myeloma or MGUS may occur differently in African Americans. I'll focus a little bit about what are the genetic differences we understand are present in a myeloma patient, not why it occurs in African Americans, but once the patients develop, how does the myeloma of an African American differ from a non-African American genetically? Also, do patients, African American patients with myeloma present the same way as, let's say, whites? Are there any differences in how patients receive their care? Are the outcomes different from treatment? Is survival different? And then kind of a little bit of overview or just a summary. So touching upon genetic differences, studies like COMPASS from MMRF are hopefully getting us to the point that we are being able to understand this a little bit better. I should say that while we have started understanding the genetic differences in myeloma between African Americans and whites, and let's say now even Hispanics, our understanding is relatively at its infancy. We still don't know a lot about this. What we do know from a couple of studies, one is from the MMRF COMPASS analysis, and one, a study that was published in, I think, 2013. I'm sorry, I'm going to go back to that slide. Is that some of the high-risk features in myeloma occur less frequently in African Americans, which means that African Americans have a lower risk myeloma as compared to whites. That is what is being shown in this particular slide, and I know there are lots of bars and lots of plots, but one of the highlighted area, which is highlighted in that red oval, shows that, for example, one of the very high-risk myeloma mutation called the deletion 17p occurs less frequently in African Americans. That said, I still think that more work needs to be done, and we will hopefully understand this further, but that is at least a starting point of why or how the myeloma in African Americans may be genetically different from other races. Then this next slide is talking more about the clinical presentation in patients. This was a study we did from a large database, the SEER Medicare database, and we wanted to see if once patients present with myeloma, do African Americans and whites and Hispanics, do they present the same way? And what we were able to show that, you may remember that Amy mentioned the CRAB criteria, which stands for calcium, renal or kidney, anemia, and bone disease. And what we noticed was that the CRAB criteria, most of those features from myeloma are seen much more frequently in African Americans, with the exception of fractures. So increased calcium, anemia, which is low red blood cells, need for dialysis, kidney dysfunction, all of that occurs much more frequently in African Americans, not only at the time of presentation or new diagnosis, but also after diagnosis. As the patients live with myeloma, African Americans are more likely to have low hemoglobin or anemia, kidney dysfunction, need for dialysis, or calcium problems. As I said, the exception is fractures. African Americans have lesser number of fractures at the time of diagnosis or even after the myeloma diagnosis. As they go on in their journey with myeloma, African Americans have less of fractures. Now that kind of goes with the fact that African Americans have a better bone density or stronger or higher bone density, and there are some studies out of orthopedic or bone journals that have shown that. So hence, African Americans start with stronger bones and are likely to have less bone-related complications. Then I'll touch upon disparities in myeloma care among African American patients. I'll be frank, I could probably talk for a full hour just on this topic because there is a lot of interest in how care is delivered to patients with myeloma, and is that care different across races. So these are some of the studies that we've done and some of my other colleagues and friends in the field have done. I'll touch upon some of these, but what we know is that this first bar on the left, the column, the time to therapy initiation, we know that the median time to first-line therapy, median meaning the most common time when a patient reaches their first-line treatment from the time of diagnosis, this median time seems to be much longer in African Americans. So African Americans are likely to receive treatment later for their myeloma. We also know that African Americans are less likely to ever initiate therapy for myeloma. Now that in today's day and age is very hard to explain and fathom, but it suggests that African Americans are less likely to even receive treatment as compared to other races. And I'll say that most of these analyses were done comparing African Americans and whites. Then the center column, which talks about utilization of novel agents, we know that the median time from diagnosis to any newer therapy, the newer drugs meaning groups called proteasome inhibitors, which includes drugs like bortezomib, carfilzomib, ixazomib, or another group of drugs called immunomodulatory drugs, which has agents like thalidomide, lenalidomide. So we know that the median time from diagnosis to any of these newer agents is much longer in African Americans. And in fact, there are now at least 2 or 3 different studies, 2 of those are our analyses, showing that African Americans have the lowest utilization of a drug called lenalidomide amongst all races in multiple myeloma care. Now, lenalidomide, like some of the other drugs, is a very important drug associated with better outcomes in myeloma patients. So it has already been noted in 3 different studies, in fact, that lenalidomide is used at the lowest rate in African Americans. Also, in another study with one of my colleagues from George Washington University, it was shown that African Americans had about 20%, 21% less, were less likely to utilize bortezomib therapy as a part of their initial treatment. Again, we know that bortezomib is a drug which has improved patient survival, so it seems that some of the effective drugs or cornerstone drugs are either not being utilized enough or being utilized a little bit too late. And then the right column talks about the use of stem cell transplant. There are now several studies showing that African Americans are much less likely to receive stem cell transplant for the treatment of myeloma. And stem cell transplant is considered one of the cornerstones of management. But there is, of course, some good news. The good news is that there are some studies that have shown that when African Americans receive care in what is called an equal opportunity or equal access system, then their outcomes are just like whites, just like non-African Americans. The left-sided curves on this particular slide, this was a study that we published earlier this year looking at almost 10 years worth of data from national clinical trials. And what it showed was that irrespective of how the patients presented, even those high-risk clinical features like the anemia, kidney dysfunction, et cetera, when patients were treated in national clinical trials, African Americans and whites had similar outcomes, or they responded similarly to those treatments. Similarly, this was on the right side, this was a study out of the Department of Defense showing that when patients were treated at Walter Reed Medical Center, African Americans and whites, when they got similar treatments, their outcomes were similar. So what this is explaining to us is that when patients get access to the right kind of treatment at the right time, their outcomes are good. This is very reassuring. I want to touch upon survival of African American patients. Now, this is where the discussion becomes a little complicated, but also interesting. Now, we know that African Americans, despite the fact that they have myeloma much more frequently, their survival is similar to, or in some studies it has been shown better than whites. Now, the thing that we need to wrap our brain around is and understand is that I've been saying African Americans get to treatment later. They may not get to the right treatment on time, and they may not be treated that frequently or as much as they should be. But at the same time, you remember in the beginning I mentioned that African Americans have a lower incidence of high-risk disease, which means high-risk disease does not occur that frequently in African Americans. So that may be contributing to the fact that African Americans actually have slightly better survival than whites. We also know that this is despite the fact that there is lack of access to some of the newer drugs. The one thing I should say is that I've been looking at this for the past several years now, and in 2012 we published a study out of a national database where it showed that African Americans had a superior survival than whites. But a study was published earlier this year by our group, and then another group that published last year, which showed that actually survival was similar between African Americans and whites. So I don't know if there are changing trends, that there used to be superior survival and now there is none, but we know that survival is either, in African Americans, is either better than whites or at least similar to whites on a national basis. So just some summary slide where I'm saying that survival of African Americans in multiple myeloma is similar to or better than whites, despite the fact that there is lesser access to or delayed access to newer drugs, despite the fact that African Americans get stem cell transplant less frequently, and despite the fact that there are higher increases in cost of care for African Americans and minorities. I didn't share that data, but we've published that also, that African Americans get a higher increase in costs of care, and there is some better disease genetics amongst African Americans. So a provocative thought in my mind is that could we improve the outcomes in African Americans even better if we could address these disparities in care? With that thought, I'm going to turn the mic over again to Mary to kind of go over some summary.
Thank you very much, Dr. Alawati, and thank you also to Dr. Kozin and to Amy for your presentations. And now we're going to move into the question and answer portion of our program today. We've got a few minutes to ask some questions. So as a reminder to the audience, if you'd like to ask a question, just type it into the Q&A box and click enter. The questions will be answered in the order in which they're received, and due to our time constraints, we may not be able to answer all of the questions that come in.
Mary, could I say something?
Yes.
This is Wendy Kozin. Two things. One, I would say if people have additional questions about risk factors, they could email me, so you feel free to give my email. And second, I wanted to clarify the differences in the genetics. When I was talking about the genetic that we found that we couldn't find specific differences that explain the risk, those were genetics in germline, which means in all of the patient's normal cells. And what Dr. Alawati was talking about is when you get a cancer cell, you get special mutations that are not present in any other cell, and those are the tumor genetics. So the tumor genetics are different than the germline genetics that we look for as genetic risk factors, just to make that clarification, because it sounded like it was not, like it was contradictory. So those are the two things that I wanted to say. Thank you.
Okay. All right. Thanks, Wendy. And as we were talking about risk factors here, I'm going to ask you, Wendy, the first question. So we had a listener write in a question. She is the daughter of someone, of a mom who has been diagnosed with myeloma. And her question is, do you think that she should request screening? And I think she said she's 67.
Yeah, I think she should request screening for MGUS, and because I'm not a clinician, I want Dr. Alawati to weigh in on that as well. And then if she has MGUS, she could be followed because the risk is 5 times higher in African Americans. You saw that 500%, and I think that that's probably worthwhile. Sikander, what do you guys do at Mayo?
Yeah, I agree. So there are, I should point out that while we are talking about genetics in the family or germline or genetics in the tumor, myeloma is not one of those diagnoses which runs in families or is hereditary, but there are some families known in the world where myeloma tends to run in the family. So also, there is data to show that the incidence of MGUS and myeloma, especially MGUS in first-degree relatives of patients, can be higher. So by all means, it is very reasonable to share that family history to their primary care physician. It is also very reasonable to just do a simple blood test to look for any of these abnormal proteins. I would probably not suggest going to bone marrow biopsies or a lot of PET scans or other imaging studies, but it's important to be aware. Now, of course, if out of any of the listeners or families and friends, if anybody notes that for some reason they have a very strong family history of MGUS and myeloma, now that is very important to bring up to your doctors because that's where some of these genetic tests may be beneficial. That is a very rare occurrence. But by all means, screening for the abnormal proteins in the blood is very reasonable because that is a very simple test to do.
And it's done on a regular physical. It's a total protein. So when she goes to get her physical and she goes to get the look at her lab results, if her total protein is not normal, then she should tell her doctor and do the next step, which is some of the other tests that she can follow up on. And as Dr. Alawati said, it's not clustered in families, but still it's 5 times higher risk in African Americans if a family member has it. So since the test is so simple, it's probably worth doing and keeping an eye on, I think.
Right, agreed. And I wanted to ask Amy to sort of pitch in here and tell us what her experience has been with this type of request at Memorial Sloan.
It's an excellent question, and we do have family members of patients who do ask about this, and we do the same general recommendations. You know, get your comprehensive chemistries done, your complete blood counts, and just like Dr. Cozen said, if you do see an elevated total protein level, you know, that should send an alert that maybe you should do further investigation, further probing as to see why that is. People can have gammopathies for other reasons, even related to rheumatoid arthritis or other autoimmune diseases. So it's important to understand what you're looking for, but definitely if they have, the first step really would be getting those chemistries done to see if they have that elevated total protein.
And so actually somebody asked a follow-up question regarding screening, and if they asked if they had already been screened because they had a first-degree relative who had MGUS and they were found to be negative, should they be tested again in the future to make sure that they were still negative? And is there any kind of a time frame under which that testing should be done?
That's a clinical question, so I think Amy and Dr. Alawati, however, I'm going to jump in. This is Wendy again. It's the total protein is the first screening, and that's done on a routine chemistry. So I don't think it has. So if their family member had MGUS, that isn't particularly concerning because, as you saw, only 1% per year to go to myeloma. If there's a family with lots of MGUS and myeloma, that's a different story. But MGUS alone, no. But that person, if they have a regular physical, I don't think they have to do it more than once a year. They're going to see that total protein anyway, and they can keep an eye on it. And as Amy said, it can be elevated for other reasons that might have to be looked into. So, Sikander and Amy, do you have anything to add to that?
No, I actually I agree with that. If they have been screened, quote unquote, for MGUS and it was negative, there's unfortunately not a very good understanding of what that timeline would be. We know that in African Americans, like Wendy mentioned, MGUS tends to occur at an earlier age, and the conversion from MGUS to myeloma tends to occur at an earlier age. But when would someone go from being perfectly normal to the first time MGUS is diagnosed? That is not that understood, and I don't think we can predict that. But this is something which can be looked upon very easily from just routine blood work. Now, of course, if you were to look at the symptoms of myeloma, they could sometimes be very, very non-specific. So I don't want anybody to start worrying that, hey, I'm fatigued, so I've got myeloma. But just being vigilant about labs, and more importantly, I would very strongly suggest make sure your doctor knows about these family histories, et cetera, because that's where the physician's job comes in, because they will play that role. They will play that quarterback role where they will look at the symptoms and try to connect the dots if something was changing.
Okay, great. We're really running out of time, but there's one more question that I wanted to ask all three of you. It's a very astute question from a listener who was talking about the fact that African Americans either, in some cases, show that they've had no treatment for their disease or their treatment starts later. Is this because they may not be aware that what they're actually experiencing is myeloma? And how similar are the symptoms of myeloma to symptoms of other diseases that it might be mistaken for and lead to a wrong diagnosis?
Sure. So
Sikander, go ahead.
Yeah, so part of that was what I was sharing. So I should say that all these studies where we've said that the patients receive treatment later or may not receive treatment, those studies have the starting point at the time of myeloma diagnosis. So all of those analyses out of SEER, which is a national database, out of Medicare claims data, et cetera, they start from the myeloma diagnosis. So it's not that the patients may not have received treatment because they had something else going on or that they were never diagnosed. So that's to answer that portion. As far as the question being, how are the symptoms similar to or different from other diagnoses? As I said, some of the symptoms from myeloma, like fatigue and tiredness, bone pain, joint pain, they can be very non-specific. Patients frequently come and say, well, I didn't even think that this was myeloma diagnosis. I thought I just had my arthritis. I've got a bad back all my life. So I didn't even realize that my back pain that was getting worse was not the chronic issue, but this was in fact picked up when I broke a vertebra. So I think some of the symptoms can be masked. Unfortunately, myeloma does tend to be a relatively aggressive disease. In fact, in case someone has active myeloma, symptoms do keep progressing. My recommendation to patients generally is that in between their visits with doctors, if they note that their symptoms are getting worse, are progressing, then they should seek attention for it. In non-cancer causes of symptoms generally tend to wax and wane, but cancer-related symptoms tend to potentially get worse unless they are treated specifically for that cancer.
Okay, thank you. And Amy, did you want to just briefly respond to that?
So for the CRAB criteria, people can have high calcium levels in their blood or anemia or renal dysfunction for other reasons other than myeloma. So, at Memorial Sloan Kettering, we may see patients who have been diagnosed with myeloma but already had pre-existing kidney issues or parathyroid issue influencing their calcium levels and were considered as smoldering myeloma patients. And, everyone's been trying to correct those abnormalities in their blood work, and it's not really helping, and come to find out that they have active myeloma. So it's really important to understand that, yes, the symptoms of myeloma can be seen in other diseases, such as hyperparathyroidism or renal dysfunction due to high blood pressure, but it's really important to see a myeloma specialist to help tease out exactly what is the myeloma causing symptoms. Is it influencing your calcium level or not? So it's important to see someone who really understands the whole pathophysiology of myeloma so that patients do go treated adequately and not without treatment when they have smoldering myeloma.
Thanks, Amy. Okay, so we're already 5 minutes past the top of the hour, so unfortunately, we don't have any more time left for questions. So at this point, I would like to thank, on behalf of the MMRF, Amy Peer, Dr. Wendy Kozin, and Dr. Sikander Alwadi for presenting today. Great presentations, so informative. I'd also like to thank all of you for joining us on the webinar. And finally, I'd like to thank our sponsors, AbbVie, Amgen, Bristol Myers Squibb, Celgene, Genentech, Janssen, Karyopharm, Novartis, and Takeda Oncology for allowing this webinar to take place via their sponsorship. So we'd just like to send you a reminder that we will be having more webinars this year. So please stay tuned for our announcements of what will be happening next year. For any information or to register for the webinars, you can go to our website. We also have one more multiple myeloma summit upcoming that's going to be this weekend in St. Louis, Missouri. So if you live in that area and have some interest in coming and learning more about myeloma, please come to our website and register for this event. We'd be very happy to see you there. I'd also like to remind everyone that we do have resources for information on myeloma and to actually ask questions as well. You can see on the left-hand side, we have nurse navigators that you can call at any time to ask questions. And I would encourage those of you who asked questions today on the webinar that we did not have time to answer to please call our nurses, and you can get the answers that you're looking for from them. They're very knowledgeable and can point you in the direction of resources that you might need or information that you might need. And also, of course, please join us on our website or on our social social media sites to get more information on myeloma at any time. And finally, for those of you who participated in the webinar today, you will be able to view an archive of this presentation on our website. We'll be providing you with the link to this archive, which is a recording of this presentation in its entirety. We'll send you the link in an email that you're going to receive following this program. Thank you,